the memory of rainy afternoons, swingy Harlem tunes, motor trips and burning lips and burning toast and prunes. How lovely it was. Thanks for the memory of candlelight and wine, castles on the Rhine, the parking lot, and moments on the river line.
Just the last name of David.
How lovely it was.
My first name is
Many is the time that we feasted, and many the time that we fasted. Oh, well, it was swell while it lasted. We did have fun, and no harm done. So thanks for the memory.
All right, welcome back, everyone. Our next speaker is Ricardo Salazar, and he's a physician with an assistant professor in Prevention of Aging and Geriatric here at the Neuroscience Health Science Center in San Antonio. And today he's going to be speaking about treatment strategies for the management of behavioral disturbances and dementia. So please welcome Dr. Ricardo Salazar.
Yeah, thank you very much. So it's a pleasure to be here again. I've been part of this effort. This is my second visit here to the VA, and so it's a pleasure in talking to you in a very, very important aspect in dementia. Because basically at some point of these patients' lives, they're going to be facing this critical behavioral disturbances, which the families are affected, the caregivers are affected, and we need to tackle the problem from the beginning. So basically, behavioral disturbances occur frequently in the dementia patients, and the focus of the talk today is going to be actually very practical, because I really want to comprehend how much relevance this is. You know, patients that are there with the diagnosis struggle in the relationship with their caregivers, and probably that's going to be the focus of my talk today. Is going to be related on how important clinicians like myself need to work together in an active role with the caregivers out there. So without a caregiver, clinicians are lost, you know, patients are lost, the systems get affected, and it's like a domino effect. So I praise the caregivers that some of you might be present in this talk here today, because you guys are the protagonists of this talk today. Okay? So, let's see. So I don't have any disclosures to display today. Basically, when we talk about this topic, we have to refer to different guidelines. So searching the literature, I came across with this initiative that is at Brigham Women's Hospital, the Department of Internal Medicine. So it was developed at Harvard by this company, which is called the National Association for Research, and it is kind of very important when you look for a guidance in what we need to do with these specific patients. Another guidance that will look like geriatric psychiatrists are in the United Kingdom. You know, the National Institute of Health and Care Excellence really provide the most comprehensive approach for the underlying causes of the behavioral and psychological disturbances in dementia. We also look into the leaders of the American Psychiatric Association, the American Geriatric Society, And most recent guidelines that I'm going to talk about later that were developed by a multidisciplinary team of what they call national experts in the field of geriatrics. So they came together, geriatrics psychiatrists, geriatric medicine doctors, behavioral scientist doctors, nurses and pharmacists came together with what would be the best approaches to tackling this big problem. So, and they all came into the conclusion, this is a very important statement, if you see at the bottom, all recommended the use of non-pharmacological behavioral strategies as the first line of management of these disturbances in dementia. So we as doctors sometimes think that medicines appeal for everything, like for every single thing that we are facing in our clinical scenarios, we are accustomed that we need to fix it with a pill. So there's another interventions that are proving to be even more effective than medications. So that's what we call non-pharmacological interventions, and that's what I'm going to be referring the talk today. So basically, I'm using this statement of one of the creators of the talk that is Dr. Fisher. He's an associate professor of medicine at Harvard Medical School, and he's basically the one who leads this initiative at the Division of Pharmacoepidemiology and Pharmacoeconomics. So he knows what he's talking about. And even him talks about how important it is in the management of the behavioral and psychological symptoms of dementia, calling here DPSD. So I'm going to refer to that mnemonic very frequent in this talk. So please be aware that every time you see DPSD is related to the behavioral and psychological symptoms of dementia. So that's how you find it in the literature. Other terms that are being used in research are called the neuropsychiatric symptoms of dementia that are frequently used as well, or what we call problem behaviors that need intervention. So basically they talk about the importance of algorithms in the approach of this problem. And a key point here, when we talk about psychoactive medications, that they should be used with very great caution to minimize the harmful effects that even these agents can cause to fragile older patients with dementia. So that's what we're going to also talk about, how these medicines are also, are at increased risk of harm. The most recent literature is reporting, very, very large body of evidence that these medicines could do more harm than benefit the patients with dementia. So we need to be very careful. So these are general recommendations only. So specific clinical decisions should be made by treating physicians based on individual patients' clinical conditions. So the clinician's judgment is a very important thing that we need to take in consideration. So it's not one size fits all, okay? You have to individualize the treatment for every single patient that you see. So that requires a lot of effort, community effort, that starts at the office of the physician, at the different community centers where the Affordable Care Act is called. The integration between community leaders, community centers and behavioral health centers. We need to start seeing also these patients with diagnosed dementia at an early stage. So the focus of this talk is on community willing people. I'm not going to talk much about how you handle behavioral problems in a nursing home or long care facilities. I'm talking about the caregiver that probably is sitting in this room, or a family member that has struggling out there with that family member, and they don't know what to do with the patient. So the family
And were you
caregiver.
guys able to change the setting where they can? Thank you. All right, thanks, Richard. Bye.
Is that me or?
Well, now we know where it's plugged in at, behind the TV. It's trying to call it.
Should I stop or continue?
You can ask them to mute their mic.
Can you mute your mic, please? Thank you. Yeah, the remote sites? Okay, thank you. So these are the goals of my talk. So you know how important it is to empower the role of the caregivers. Again, caregivers, that's the key. Also, a meaningful reduction in the use of psychotropic drugs for the symptoms in community well-being adults with dementia. So I hope that after this talk, you're going to greatly be inclined to the use of minimizing the use of psychotropic medications. And we really need greater support at a local, state level, national level, to real-world implementation of non-pharmacological interventions, including the training needed to educate caregivers about behaviors and environmental approaches. So basically, let's take a look at the numbers. So it doesn't look very promising what we're going to be facing in the future. So these are projections in millions. So in 2013, there were around 47 million of patients with dementia. Not only Alzheimer's disease, but this is dementia in general. And by the year 2030, they are expected to double. And in 15 years from today, they're expected to, in the year 2050, they're going to triple. So it's going to be an epidemic, and we need to be prepared for this. So that's something that we need to take in consideration. So this is important. So the model. So it's very important when you're thinking about when you're trying to do interventions. You have to think about the patient with dementia, that I call the host here in this figure. You have to think about the environmental or the environment where the patient lives and where you can tackle with non-pharmacological interventions. And also, to your right, you see another important part of it, like we see like a sickness, or what are those behaviors that sometimes in very specific situations you do need to use pharmacotherapy because it is an imminent harm for the patient or the caregiver, and you have to intervene with medications. But that should be the last resource. But what is wrong with this model? So what is missing there? Absolutely. So who is the most important person? All right. So remember that, okay? The caregiver, always. So we need to empower the caregiver. We need to work with the caregiver all the time. And I will explain how we do that. This is just to compare how the chronic model works out there. So, and this is there's a stigmatized dementia. We're now using in the DSM-5, that dementia is a neurocognitive disorder, but you cannot use the term this patient is demented, by using this patient is neurocognitive disorder. That's more like a term that we use in order to say this patient needs help and assistance. So we need to empower the patient as well in the discussions. If possible, we have to have the patient in the room with us. So we have the caregiver, we have the patient, and we have a productive relationship between the clinician, the caregiver, and the patient. So we need to we need to, integrate the patient in our evaluations and become proactive. So that's very important. And then, like I was saying before, the community resources, the health systems are changing, and we need to act. We need to start doing things. Again, this is, I don't know if any of you here in the nursing field know about Pamela Larson. She's been a pioneer and a long-time researcher in the evaluation of impacts of interventions in chronic illness. And dementia, for sure, is a chronic illness, And they say the best outcome of clients with chronic illness, like dementia, will be the healthcare professional supporting and assisting the client through the illness experience. But again, what is missing from this statement? The caregiver, right? Sometimes we have healthcare professionals that are caregivers as well. So they need to work together with family caregivers. So those two are essential in the treatment of the patients with these disturbances. So basically, millions of dollars are expended to try to find the causes of Alzheimer's disease and different dementias, and we concentrate mainly on the cognitive aspects of the condition and memory loss and all that. But the behavioral and psychological symptoms of dementia are even more burdensome for the families and the caregivers, and really need to pay more attention to this. So research is coming along, for the past 10 decades where reviews and the literature is coming along, but we're still struggling. And to be honest with you, in terms of the interventions, the only one that stands is the non-pharmacological management for behavioral disturbances. The evidence of medications is still very weak, very controversial, just modest responses, and only for specific behaviors, like this one's in this slide: agitation, aggression, and sometimes even very difficult for patients with psychosis. But you have to use your clinical skills, and that's when the clinician enters the role, how to use their skills and their knowledge and their background to kind of try to navigate this complexity of difficult presentations. And so the burden to the family members and caregivers are just incredible. So, like I'm saying, it's not even frustrating for the caregivers and sometimes for the patients interacting with their families, but also for the clinicians. We don't know what to do when these patients walk through our door. We don't know what to tell the family members, but we need just to be really well informed, because it's not about medicines, it's just about education, taking the time. And sometimes with how the system is changing, like you have 5 minutes to see a patient, that's not going to work. Antipsychotic medications are frequently used as part of larger pharmacological armamentarium in treating patients with these conditions. But the morbidity and mortality is incredible, a problem. So again, non-pharmacological interventions pose fewer risks. So here, so what is the definition so when we're talking about the behavioral and psychological symptoms of dementia, we're actually talking about psychological reactions, psychiatric symptoms, and behavioral disturbance that occur in a constellation or in a repertoire that we don't know when they're going to appear. These patients sometimes, the frequency of that these symptoms occur are exponential, like as the disease progresses. Like there's a study reported by, Konstantin Lakaitos, that is an authority on this research, that in community dwelling patients with dementia and Alzheimer's disease, the symptoms were up to 60%, so that's quite high, out there in the community. And when you look at the numbers in long-term facilities and nursing homes, these numbers go up to 80%. But overall, at the end, if you measure during the lifetime of the progression of the dementia, at some point in time, these patients are going to have some of these symptoms. So we have to organize, because the brain is coming like the brain matter atrophy occurs in different regions, and these symptoms are emerging as the disease progresses. So as the neurodegeneration continues, and there's some deterioration in some brain structures at the level of anatomical structures, at the level of functional, with the modern neuroimaging is showing that, and also at the level of the neurotransmitter systems, we're going to talk about in a few minutes. So this is important. This slide is very important. What are the factors associated with the behavioral and psychological disturbances in dementia? So we have these layers of neurodegeneration that I was referring to, which provoke even increased vulnerability to stressors. So those two are, by directional way related to the behavioral and psychological symptoms of dementia. And there's also patient factors. So that's what we're going to tackle this problem by thinking about those things. What are the patient factors? What are the environmental factors? And what are the caregiver factors that also are intuitive to this dynamic relationship between these important relationships that you see here. So can you clearly see the grid that over there? Are you able to see it? No? So it's hard to read. So I'm gonna go through to the left. So you can see like the patient factors are basically what we call premorbid personality disorders. So you need to know this patient's back history of their psychological traits, like how is this patient's personality. If the patient used to be, in the military, he used to be a cop, he used to be in charge, he used to do, manage. So aggressive patient. So as the brain starts to, being affected by dementia, those behaviors for sure are going to come out, and it's going to be a problem. So knowing the personality of this patient is essential to prevent and to start acting if we start seeing the first signs and symptoms. Also psychiatric illness. So that's something that we know as psychiatrists. Like these patients, if they have comorbid psychiatric conditions like depression, bipolar disorder, schizophrenia, anxiety, those are things that sometimes we can intervene in with medications and or psychotherapy, and we can probably ameliorate the severity and the frequency of the symptoms. So that's important. Also, patient factors include acute medical problems. Like, what do you think is the most common acute medical problem in the elderly that sometimes we kind of forget?
Hearing, vision.
Yes, so yeah, that's very important. But yeah, from the perspective of investigations, we frequently forget urinary tract infections. So UTIs are the most common cause of behavioral disturbances in the elderly. So I'm referring to this slide over here. So I'm sorry if you cannot read it well. I'm sorry about that. So also constipation, pain. So that's frequent. UTI, constipation, pain is unmet needs. So is the patient having, is the patient cold? Is he lacking sleep? You know, is he hungry? Sometimes these patients have the, you know, early in the disease process or in the middle, they start losing their way of communicating effectively with their family members and caregivers, and the only way they might come along with what they're feeling inside is just by, you know, acting out with the symptoms. So that's important. Now, so the caregiver factors is very important, because sometimes caregiver factors include the caregiver burden. So the caregivers are stressed out, you know, so that's down here. They suffer from depression very frequently, and they neglect themselves, their health. So they really need some respite and to take care of themselves, to go to their doctor, to start doing some exercise is important, you know. Communication issues, you know, sometimes there's conflicted communication between the caregiver and the patient. And the mismatches expectations between the patient and the caregiver. So all these things increase vulnerability to stressors. And then we have you have here the environmental factors that someone brought it up here here at the front, is the lack of having you know, an overstimulated or understimulated environment. So if you don't have good vision and hearing, so that could be misperceived by the patient and can generate a lot of troubling behaviors. So the lack of activity, that's a very key point, and structure, and the lack of established routines. So I couldn't emphasize more about that. The lack of activity and structure, and the lack of established routine. So these patients sometimes, if you change them, you know, the timing is always at the same time. You know, you don't follow schedules when you're working with the patient, so they don't get it and they become agitated and frustrated. So that's important right here. So I'm sorry about this slide. I thought you guys could read it better. So in terms of assessment, let's touch a little bit more about the neurobiological underpinning of this condition. And we can summarize it on this slide over here, where we basically describe the neurology or behavioral and psychological symptoms of dementia. So you have it at a structural level. So it has been proven by these new imaging studies that we can picture, you know, the locations of the neuritic plaques and neurofibrillary tangles in the brain, and the ones that are related with the frontal lobes and temporal lobes are really associated with the PTSD at different locations, right, more than the left, and it is particularly on the right, so what we call this misidentification syndrome, DMS. So these patients start losing in a delusional way, like they don't know their home, or they start having problems in identifying close family members, and so on. And then the neurofunctional disturbances are measured by how the different, at the cortical level, there's different neurological loops and neurocircuits that alter human behavior. So basically, the ones that are more studied the most are the ones that have to do with the dorsolateral prefrontal cortex that occurs, executes like planning, you know, and executive function.
Hello, welcome to the conferencing system. To join the conference, use the far end camera control.
And at the neurochemical level.
Finish through, and then you can resume. Your mic is off. All the microphones are off right now.
Really?
Yeah, because there's people talking. I don't know what's going on. Let me see the background.
In the meantime, sir, can you,
Yeah.
what is DMS?
Yeah, this is called, it's at the bottom, delusional misidentification symptoms, and that's very frequent. Like the patients start losing their ability to recognize their own home, or even family members. They lose that ability. And it's mainly because of the structural changes in the brain, because these plaques and tangles in the frontal lobes are progressing, you know. And mainly on the right frontal lobe. As you know, the right hemisphere is in charge of spatial orientation sometimes, but at the frontal level is more like identifying objects and even people. So that's important. So now at the neurochemical level, are you guys hearing me?
Yes.
Good, okay. At the neurochemical level, so look at this, there's damage, we know this. There's damage of the cholinergic neurons in their projections to the frontal and temporal cortices, and also the monoaminergic system is disturbed. So that's why some of the medications might have some role in management of these disturbances. And then this is highly interesting, you know, genetic plays a role too. In patients that have a family history of a first-line relative with depression, there are increased risk of suffering from these disturbances with that heritability of that is quite high for psychotic symptoms. Do you see that slide at the bottom? Genetic, can you see that? It's almost 30 up to 61%. If you have a first-line family member with depression, the heritability of psychotic symptoms are between 30 and 61%. And also, ApoE4, like you guys are very well aware of, depending of the presence of absence of those as associated with depressive symptoms, and other polymorphisms are related with psychosis and aggression, right at the bottom of the slide. And then, like I was talking before, the psychological aspects is a high promoted level of neuroticism in these patients is associated with depressive symptoms.
May I ask you something?
Yeah.
If by its very nature you have dementia, which the symptoms mimic mental illness, why are we setting aside different drugs for each? You have a set of drugs for somebody who has the dementias, and then you already have established medications for those with mental illness. Why not just give them if the symptoms
So yeah, that's where art comes into play.
Where what?
Art. You know, you have to use those in your advantage. So if you have a patient with a psychiatric disorder, so probably it might be better served sometimes in treating the underlying psychiatric conditions, you know, with the appropriate medications. Because sometimes it's different if you have a late onset, what we call, let's say, depression, right? If you have a lifetime depression and then you become demented, so that's a different deal. That if you develop late onset depression, usually late onset depression is associated, that is related mainly with dementia. So it's a symptom of dementia. Depression becomes a symptom of dementia, and then the deal is different. Then the studies do not support the use of antidepressants. They can be more harmful than beneficial. You see what I mean?
Not really.
So it's very complex. Yeah. So unfortunately, there's not a straight answer, you know. And when you're desperate, you know, that's when you feel pressed to decide. And we'll talk about it in a minute, you know, if the risk and benefits really.
Well, I just thought the medications were for the symptoms, and again, they almost mirror each other, and the majority of what you're getting in dementia patients are what you have in mental patients.
But they don't work, you know, unfortunately. They don't work. Yeah.
Or either? Wow.
Yeah.
Okay.
Well, okay, let me be clear with this. As of today, there is no modifying disease medication that it will slow the process or treat effectively any of the symptoms at all. And also, there is no FDA-approved medication for the use of the behavioral and psychological symptoms of dementia. So you're walking in eggshells when you're addressing the problem. Yeah.
Sir, is it not true that, for what she's asking, the question that she's asking, is that a lot of times those symptoms look mental health, but they're not mental health. They're as a result of the changes that are happening in the brain.
Right.
And so it's difficult to use those type of medications to deal with a person with dementia because they don't have the same problem.
Yeah, that's what I say in different words.
Yes. Yeah.
Thank you.
So,
Thank you for clarifying.
you're welcome.
Yeah, that's what I just said.
That's what I thought I heard you saying, sir.
Yes,
Thank you.
yes. So yeah. But sometimes we're in a conundrum because we don't even know. Sometimes we don't have informants. We don't have reliable proxies to tell us the background of this patient, and we're lost. So we need to do our better. So that's why, again, the caregiver is essential, and non-pharmacological approaches. So what I was going to try to get with this slide again was when we talk about acute medical conditions, and I think I already referred. I'm going to get over here and see if really it's pretty bad. Let me see. It's not that bad. So what I'm referring to, the acute medical conditions, is over here. So in assessment, so never forget that as a clinician. So never forget that as a clinician, that the most frequent problems are UTI, constipation, undiagnosed pneumonia. These patients, they're agitated and they're gasping for air, but they don't express themselves effectively, and if we don't do a pulse ox, we don't know that we might be cooking, lower pneumonia. Remember that elderly patients do not throw a fever many times, and the only way they might manifest pneumonia is by screaming out, crying out, yelling. So you have to be careful. Dehydration is a very, very important aspect as well. So let's continue here. Yeah, I like the mic better. It gives me more flexibility. Can you hear me better?
Yes.
Good. Okay, so I'm supporting the Alzheimer's Association here with the, the color. Caregiver. We need to give funding for the caregivers. They are the most important part of this aspect. We really need to invest in caregivers. They are demand, and they are demand. Okay. So the arrow is showing me to start talking about the environmental, the non-pharmacological approaches, interventions. So here we are. So when we talk about non-pharmacological treatments for the behavioral and psychological symptoms of dementia, we are talking about 3 levels. Those targeting the person with dementia. Okay? So that's the role of the physician most of the time, by your knowledge. But you have to empower the caregiver, because who's the one who's dealing with the problems? The caregiver. Who's the one who can, intervene and make sure the patient is doing what you're telling her to do? The caregiver. Exactly. So also, those targeting the caregiver and those targeting the environment. So please, do not forget this slide. Non-pharmacological interventions is the way to go. Okay, as the first line. So, NPT means non-pharmacological treatments. So when you look at the literature, so this is not what I'm talking about, non-pharmacological interventions. The literature is very weak and inconclusive in all of these interventions that are listed on this slide. And that's what people think is non-pharmacological interventions. You know, they might help sometimes, or they say, no, music therapy, you know, but that's not all. And that's what we're going to talk about. So, reminiscence therapy, you know, discussing past experiences, validation therapy, working through resolved conflicts, simulated presence therapy, you know, the use of audio tapes, recordings of family member voices. Please do not use it in a psychotic patient, right? You know? So you need to be cognizant of what's going on. Aromatherapy, sometimes, yeah, it does provide some calming effects, you know, but we will say aromatherapy to cleaning the clutter at home. That's even more effective than just, you know, providing too much stimulation. So you have to be careful, because in patients with dementia, so the brain is kind of, I mean, I'm sorry to tell you, but the brain is kind of melting, you know, by different regions, and so through the senses, sometimes they get overstimulated and they react more. So the snuzzling rooms are used sometimes, but that can create more agitation sometimes. But sometimes works. I'm not saying it doesn't work. I'm not trying to tell you not to use any of these interventions, because they do work sometimes. So whatever works sometimes that is non-pharmacological, you know, try to use it, and you know, that's good. So cognitive training and rehabilitation, acupuncture and light therapy. So all those things are being tried, and they're being studied, you know. There's randomized control trials and different types of meta-analysis that are having to look into these things, but unfortunately, there's no conclusive you know, recommendations. They can say not do it or do it, you know. It's just inconclusive. All right. So this is what it really works. You know, the non-pharmacological treatments, interventions with family caregivers or professional caregivers. So that the literature is very robust, you know, in showing how important these interventions are, you know. So so some of the most large, you know, clinical trials are there. They were problem solving, you know, identifies precipitating and modifiable causes of symptoms, followed by efforts to modify these causes with selected non-pharmacological strategies. So those are the studies that were done in patients in the REACH-2 and REACH-D8 study that were done basically in very, they invest a lot of money in providing basically excellent mental health care in the community for civilians and the VA patients. I don't forget what REACH stands for. My computer here just went off, so I'm not going to do that. But they were, you can look it up, and they were just very, very conclusive studies, very well done, in which they empowered the caregivers. They provided training, they provided education, and they just worked with the caregivers in different sessions. The Taylor activity program basically included also healthcare professionals and what we call occupational therapists that were working in the home with the caregivers and the patient, and they were also training the caregivers in how to manage these problems. The care of persons with dementia in their environment, the COPE study, and the advancing caregiver training study. So all those, the very robust results that are really telling us how important it is to train the caregivers. And I'm going to be more practical at the end on how to do that. Now, at the environmental level, the studies also target, you know, things like excessive noise, or people, or clutter that I was talking about. Target overstimulation, like the lack of anything of interest to look at. So you need to be careful when you're dealing with those patients at home. What are they doing and putting to do something? And target the safety problems. That's very important. No access to guns or sharps or anything that they could do harm or harm themselves with. Household chemicals. Lack of established routines. That's what I was talking about. So it's so impressive how we just take it for granted and we don't follow this, but it's very relevant. You know, you need to do a routine in a patient that is dealing with this problem. So we have to wake him up at the same time, you know, the bathing and grooming, and, you know, and let's go and do a walk, and we're going to do this activity, you know, engage, you know, exercises, all that is so important. So the lack of activity or structure is detrimental for these patients, and it's something that we can do. Okay? So bottom line, the non-pharmacological approaches with the strongest evidence base are those based on family caregivers interventions, which have been shown to have a greater effect than even antipsychotics. If you look at the side effects, the size effect, when you look at the numbers with the methodological approaches, so basically they're even greater than antipsychotics. Antipsychotics are very minimal, like 0.13 to 0.3 or 0.7, and individual medication sometimes greater, but only to specific kind of behaviors. But in general, they're very poor, and even these approaches are better. The ones that are targeting the caregiver. So these approaches include. So I already mentioned them to you, so you can see it in this slide. Okay. Increasing the activity of the person with dementia, enhancing communication with the person with dementia, reducing the complexity of the physical environment. Sometimes we forget about that. So, because we are not ready to adapt as our relative, our loved one with dementia. But we need to do that if we want to help and reduce the symptoms. Simplifying tasks also for the person with dementia. You know, increasing communication is do not argue with the patient. Do not be explanatory. Just be very simple, you know, and very, you know, communicate with him in a very calm demeanor. You have to smile. You have to look at his eyes, you know, in a calm form, and use very simple terminology. Do not try to explain or repeat or talk about future plans. That doesn't work, you know. Just the now, okay? So, like I was saying, non-pharmacological treatments of dementia also might have adverse events. So the things that I was that I was telling you, you know, patients, music therapy, massage and touch therapies and aromatherapy sometimes are reported with increased agitation. So you have to be careful, you know, when to use it, and so to be cognizant of that, you know, and also even that they don't carry, you know, higher risk like the drugs, you know, but it can be disturbing sometimes. Okay. I'm going to go really quickly because this is not the focus of my talk, but also they think that if you centralize the non-pharmacological management interventions, but not on behaviors, but on cognition, you might diminish the symptoms. So, but they are at an early stage of development, and basically, bottom line, those are cognitive stimulation, cognitive training, cognitive rehabilitation. They might have some reminiscent work, validation therapy, snoozling stimulation. Really, it's debatable just read the last one. The impact is debatable. It really doesn't work really well. So when we're talking about basically here, no randomized studies directly compared with cognitive stimulation, with medication such as the cholinesterase inhibitors that are to target cognition are really out there. There are other trials we try to use the cognitive stimulation program in patients with mild to moderate dementia. And it did improve on some modest statistical significant benefit, but still more work to do in that area. So bottom line, they really, they're not effective, okay? Right here. But I just need to highlight that, the bold letters. They're implicitly used to preserve, autonomy. That really helps, in a temporary way. They do improve a little bit of quality of life and might reduce caregiver burden. But I'm not saying this is more in terms of the cognition, so I don't want you guys to get confused. So you can start doing those things while you start planning for legal issues, financial planning, healthcare proxies, and advanced directives, but evidence is still limited. So going back to the model, so this is where I enter here with the host, the patient with dementia. So you have to have this background, that we're dealing with different types of dementia. That the patient out there, and the majority of them, of course, 90% of the cases are patients with Alzheimer's disease. And this is the main purpose of the tunnel. This is the main literature out there is in Alzheimer's disease, the behavioral and psychological disturbances of dementia in patients with Alzheimer's disease, because it's the most common. 90% of the cases, up 60-90%. So the clinical features so you need to keep this slide in mind when you're treating patients, because let's talk about vascular dementia. So those patients are at increased risk of strokes if you, let's say, decide to give them an atypical antipsychotic medication. So you see, Lewy body patients also. These patients, they deal with visual hallucinations, so they are extra sensitive to a typical antipsychotic. So you think, oh, he's hallucinating. We can give him an antipsychotic, doctor. Why don't you give him an antipsychotic? This patient is hallucinating. He's seeing the little children, and he's going after them. And we think we need to give them medicines. And it's more like providing education that these behaviors are really part of the disease process, unless they are not an imminent risk of hurting anybody or hurting themselves. So we don't need to intervene very much, at least not with antipsychotics. That will be the last resort, and we'll mention about that in a little. So that's why you have to keep this slide in your mind. What is the type of dementia that I'm treating? So that's important. Sometimes it's substance induced, and what you need to do is just stop the medication. So reducing polypharmacy is related with good prognosis. I mean, when you decrease the polypharmacy, these patients get better. So you need to identify what is that particular medicine that is affecting the brain function. Particularly, anticholinergic medications are well known to just cause more problems than any benefits. And then treat the underlying cause. If the patient has HIV, so you have to do the workup initially, right? So if you treat the HIV dementia, so the patient usually improves their behavior. So with art therapy, Huntington's, unfortunately, there's no cure for that either. Prion disease, that's pretty rapidly progressive. dementia. There's basically no treatment. And of this one is frontotemporal dementia is probably one of the ones who have more consistent manifestations with behavioral and psychological symptoms of dementia, because it's in the frontal lobe where the symptoms emerge. So these patients are, completely out of control, and they're very challenging to manage. Right? So we need more research. We need more funding on FTD cases too. So this is, I'm going to go quickly to this. So this is what doctors do at their office when they're seeing their patients. So you have to do a complete evaluation, physical exam, neurological evaluation. I'm going to go quickly, it seems like my time is... So this slide is just to show you in a different way that managing the psychiatric disturbances associated with neurocognitive disorders needs to take in consideration that these patients sometimes in their disease process develop psychiatric disturbances, and the recognition of depression, anxiety, agitation, and psychosis, as well as apathy, in the context of any neurocognitive disorder is very essential, because we need to be very targeted treatments and optimize outcomes. So this is, I really want to mention this very briefly, because this is also a study that is being done like even 20 years ago, and we still talk about it. The famous work of Justin Rosberg was published in the American Journal of Psychiatry in '96. So we talk the brain before, during, and after. So you see the different, constellation of symptoms. So patients can present to your practice with symptoms of depression, and what they really have is Alzheimer's disease. You see? So that this is even 2 years before they have the cognitive symptoms or the functional decline that we tend to focus our attention more. So we need to be alert. And even suicidal ideations, look at that. Hallucinations and psychosis is when the disease is more kind of established, and then the most persistent and disturbing symptoms when this completely settled is irritability, agitation. This is just to document what clinical neuroscience is doing right now. So the advances of the location of specific behaviors. So how we can use this clinical translation of neuroscience in our advantage to understand our patients better. And here's this slide. So 5 minutes? Okay. So the algorithm of assessment the behavioral and psychological symptoms of dementia. So I think I already walked you through this slide. So if you can take a picture of this, that would be great. Okay? So obtain the history, complete physical examination, order the laboratory investigations, treat and address and remove the offending drugs, complete the standardized rating scales is important. The most common is the mini-memo, or you can do the MOCA, the Montreal Assessment for Cognition. And then the model here, the disturbance behaviors, again. So you have to cluster this as a clinician. So if they come, but it doesn't make any sense to me how I organize that. So you have to know the basics, which ones are emergent and which ones are non-emergent, and which ones we need to target. So that's important to differentiate. So you put them in clusters. So delusions, this is very common, stealing, when they're, trying to, my wife wasn't faithful, or things like that. Hallucinations and agitation. So those are common ones, aggression, anxiety, inhibition. And this one usually do not respond to medications, okay? There's some target sleep-run behaviors with other medications that can work. Usually that's not going to help. Or like the patient is ingesting objects. That's not going to help with medications either. So you have to put them in clusters. And so to think about how to intervene better. So for depression, for apathy, for aggression, for psychomotor agitation, for psychosis. So this is how you
you go. So again, you were referring to, so you need to characterize the level of impairment. If the patient has moderate to severe Alzheimer's disease, so the use of anticholinesterase inhibitors and memantine should be a priority before you consider any other measures like antipsychotics. This is going into like the last resort, like after you have really go through the non-pharmacological interventions and nothing has worked, you continue the non-pharmacological approaches and then you try to manage the problems with this type of medications that might help. Because the theory behind this is if you treat the accelerated deterioration, you can control the neuroscience symptoms. Okay? And these are the medicines. So whatever is not there, there's not studies, okay? And the Paxil or paroxetine is put there just to let you know that please do not use paroxetine, okay? That's not good. And also mood stabilizers, very, very poor literature on that. Or carbamazepine or valproic, very poor literature. Cholinesterase inhibitors, side effects, they don't work. When you're desperate, sometimes with patients with agitations, there's a recent literature reported in last year about citalopram and managing agitation. The antipsychotics, aripiprazole seems to be the safest. Thanks God, it's coming generic in a month or is already in scanned. And risperidone, but thiopine doesn't work. Sometimes we use it desperately for patients with Lewy body dementia. So this is the last slide because I didn't want to emphasize in medicines. That's not the way to go about this. Okay? You need to consult with the geriatric psychiatrist. And this is the DICE approach. So remember, you can please write down and just research it because this is just the latest out there. Is how you go in different stages of hierarchical importance of describe. This is working with the caregiver, the DICE approach. Describe, investigate, create, and this is just ways to create interventions that are important to the patient and to the caregiver. And here is, I'm talking about non-pharmacological approaches of managing behavioral disturbances. I'm not talking about medicines at all here. And evaluate. These are the references that I was talking about earlier. I want to thank Dr. Tampi. I think doctor and the two of them, they're great doctors, and he had the opportunity to work within the University Texas Health Science Center at the RAC, at the Valley. He's from Yale University, so he's very practical in his talks and in his reviews papers. So I use that, and also to the recent review, very comprehensive, more than 171 references by Dr. Blankets. Thank you very much. TARC sites, remember I'm involved in Alzheimer's research through the TARC, Texas Alzheimer's Research and Care Consortium. This is awesome. I'm one of the ones that is involved in the behavioral and psychological symptoms of dementia. I think is a great deal of research is still needed. And this is the contact information. Elena, can you stand up, please? Elena? Please contact her. If you have patients, we're needing patients. We are emphasizing the lack of research in the Hispanic population. I'm basically targeting the Hispanic population and the cross-ethnic differences between different populations here in Texas. So we're in great need of helping these patients. In a recent research study that I did into this data, I found that the patients with, the Mexican Americans, unfortunately, had a higher rate of frequency of neuropsychiatric symptoms or behavioral disturbances of dementia as compared to others. The only one that outrated the Anglos was an apathy. Apathy symptoms are more common in the Anglo population. So we need to intervene. Thank you very much. Appreciate it.
Thank you very much, Dr. Salazar. Okay, ladies and gentlemen, we're going to take a 10-minute break to use the restroom, to get some coffee, to stretch your legs, and then we'll resume with our next speaker, Dr. Lady Martinez, who is in the audience, ready to go. So when you come back, we'll get started with that. So we'll see you guys back at 25 hours. Thank you.
Motor trips and burning lips and burning toast and prunes. How lovely it was. Thanks for the memory of candlelight and wine.